We're recording. Perfect. Well, I'll get started just with a quick introduction of this panel and a little bit about the COVID-19 database. I think people are still joining, but I want to jump in because we have a lot to cover today. So welcome to our Grand Rounds webinar series. The Grand Rounds for the COVID-19 database is a time for us to feature research groups who've published or are progressing in their research and have some particularly important insights that we want to share with our wider research community. Today, we're looking at this really timely and important topic, the intersection of the COVID-19 pandemic and the opioid epidemic. And I'm excited to have these two groups here, particularly because they just recently published their insights on this, there's particular facets of the intersection of these two crises. A little bit about the motivation behind this particular webinar topic. The COVID-19 pandemic has worsened the drug overdose epidemic in the United States. In January, the CDC reported an all-time record for overdose deaths in a 12-month period. Opioid overdose deaths increased by 38% nationwide last year, and in certain parts of the United States, it was actually remarkably higher. In response to this crisis, the CDC, along with many state and federal agencies, is urging the expanded availability of medically assisted treatment, as well as a distribution of naloxone, a medication used to treat overdose, particularly opioid overdoses. The two researchers today, as I mentioned, have recently published their work, and they have explored the availability of medically assisted treatment for opioid use disorder, as well as naloxone availability for overdose treatment during the pandemic. And I hope you all will see that their analyses are particularly salient for current and future health policy as we try to unpack and intervene on this intersecting crises. So they both accessed the data that they're going to talk about today through the COVID-19 research database. So I want to pause and just explain a little bit about the database, because I know not everyone who is watching this webinar is familiar with the actual, where this data all came from. So the COVID-19 database is this secure repository of HIPAA-compliant, de-identified, and limited patient data sets that are made available to public health and policy researchers at a pro bono basis. And we are trying to support any non-commercial research that helps us and our communities address the direct and indirect effects of the pandemic. So in these Grand Round webinars, we've featured folks examining, research teams examining the direct effects. And then we're very excited about some of these groups who are now publishing on these indirect effects, like the indirect effect of the COVID-19 pandemic on the availability of medically assisted treatment, et cetera. And please do visit the website. We're on Twitter. We try to tweet out about the research groups who are publishing their information. So that's a great resource. And please feel free to reach out to us about your interest in the database, whether you have questions about certain data sets or the regulations around the database. Please do not hesitate to reach out. I want to just quickly give credit where it is due. These are all of the partners who make the database available. They came together in a matter of 6 weeks from brainstorm to first iteration of the database over a year ago. They continue to be committed to making this available to the research community. So we are endlessly grateful to everyone who is involved in setting up the database and continues to support the database today. The database itself, so though zooming out, the database has 87 billion records, about 250 million unique individuals, and it has, you'll see at the bottom, the number of data sources. There's 55 public data sources, so anyone can bring a public data source that's available to the community within the secure database, secure analytics layer. We also have 13 major private data sources. Both of these teams, I believe, will be talking about Symphony. That is one of the data sources available in the database. And we have a number of different organizations, international, state, local, academic medical centers, schools of public health using the database. We are thrilled that we have this growing community of researchers. We invite anyone who's not a community in this community yet to register at the website that I listed earlier, and we'll drop it into the chat as well. You'll get updates from us. You'll get invites to the future webinars, and insights. We'll also send out any publications that come out of the database if you're interested in staying in touch. So now for our panelists, I want to start with introductions. Maybe we can start with Ashley.
Sure. I'm so happy to be here today. My name is Ashley O'Donoghue. I earned my PhD in economics back in 2020, and I'm currently an economist at the Center for Healthcare Delivery Science in Boston, Mass. At Beth Israel Deaconess Medical Center. There I work on evaluating healthcare delivery, access to care. I have a particular interest in the opioid epidemic, especially how it relates to new and expectant mothers.
Wonderful. And three.
Hi everyone, my name is Thủy Nguyen. I'm a research assistant professor from University of Michigan School of Public Health. As a health economist, I specialize in addiction-related policies, the opioid epidemic, and the incentive issues of medical providers. So I would like to appreciate the opportunity to work with a lot of wonderful data sets to the COVID-19 database. And I have a lot of great interaction with the staff and got a lot of support from the team. So it's a great opportunity.
Thank you, three. And I think we're going to begin with Ashley. So Ashley, take it away. Hand the microphone to you.
Awesome. So today I'm going to be talking about trends in naloxone prescriptions during COVID-19. And this is joint work with several people, Nayanthara Biswas, Tenzin Detchen, Tim Anderson, Noah Talmore, Atulita Punamaraju, and Jennifer Stevens, which is a mix of physicians, economists, some research assistants, so a very interdisciplinary team. So today I'm going to be talking about naloxone prescriptions. For those of you who aren't familiar, naloxone is an antidote for opioid overdose. So while it's not a treatment for opioid use disorder in general, it is effective at reversing an overdose that's in progress. So it can give the patient enough time to get to an emergency room where hopefully they will receive treatment and get into some sort of treatment. Next slide, please. Just as a disclosure, this work is funded by google.org, the philanthropic arm of Google. Next slide, please. And so the motivation here is that we know opioid overdose deaths have increased quite a lot during the pandemic. So this graph on the right-hand side shows the monthly overdose deaths due to opioids from 2016 to the first quarter of 2020. And you can see the red line shows where the pandemic began in the US, and there's quite a large increase in opioid overdoses. And naloxone, we know, can reverse overdoses, so it could help prevent some of these overdoses turning fatal. So increased naloxone access is really important, especially during the pandemic when we know fatal overdoses have increased quite a lot. Next slide, please. So naloxone is interesting because it is a prescription drug, but you can actually access it in several different ways. So one of the primary ways that people access it is through take-home naloxone. So this would come from visiting your clinician or from some treatment facilities or from bystander trainings. Sometimes police departments will give it out for naloxone trainings as well. So one of the major ways that people access naloxone is through take-home naloxone from outreach from these community organizations or their doctor. But this has been significantly reduced during the pandemic because of stay-at-home orders, closures of areas where there's lots of outreach, like public parks and bus stops and things like that. There's been reduced hours at a lot of the organizations who distribute naloxone, and a lot of naloxone trainings have gone online, so they're now virtual. And though they often do mail you your naloxone after the training, it can just be more difficult to access this take-home naloxone. So we know that take-home naloxone has decreased a lot during the pandemic, but we don't know what happened with naloxones at pharmacies. Next slide, please. So here we specifically focus on naloxone at pharmacies. The reason we did this was I was perhaps naively hopeful that maybe when people were struggling to access naloxone in their typical ways, they may have been able to substitute towards pharmacy or mail order delivery of naloxone and still able to access naloxone during the pandemic. That isn't the case, which we'll show, but this is particularly looking at naloxone prescriptions filled at pharmacies. So it doesn't include take-home naloxone, it's just naloxone filled at pharmacies. One of the important things to remember is that naloxone is recommended to be co-prescribed with opioid prescriptions. So if you're prescribed an opioid, it's recommended you are also prescribed naloxone. And we know opioid prescriptions likely went down during the pandemic because of the decrease in elective procedures. So naloxone might dip a little bit because of the dip in opioid prescriptions. So we want to make sure we can compare naloxone prescriptions to opioid prescriptions overall. Slide, please. So the way that we do this is we use Symphony Health. So this is a national pharmacy claims database. It includes a really high capture rate of retail pharmacies, 92%, 71% of mail order pharmacy claims, and 65% of specialty pharmacy activity. And we've really enjoyed using this data set. It's been really a pleasure, and we're very thankful for being able to use it. And so from Symphony Health, we extract naloxone prescription fills, opioid prescription fills, and the total number of prescription fills in the data set. Next slide, please. And so we use an interrupted time series design, and this lets us estimate the change in naloxone prescriptions right when the pandemic starts, and also the change in trend. So if there's an increase or decrease in the number of people each week. So we look specifically at May 13th, 2020 until December 20th, 2020. And we define the pandemic as beginning on March 16th, which is the week following when the national emergency was declared. Next slide, please. So specifically the equation that we're estimating here for each drug or drug class, naloxone, opioids, and all prescriptions. We're interested in the beta 1 on the post variable, which determines before or after the pandemic. So that'll tell us the level trend in, or the level change in March, whereas beta 2 on the post interacted with the week will tell us the change in trend. So we're interested in both of those coefficients. Next slide, please. So what we find is that there were declines in all three groups. In this figure, the navy line at the top shows total number of prescriptions in 10,000s. The orange line shows opioid prescriptions filled in 1,000s, and naloxone is in the blue line at the bottom. And you can see they all decrease. There's a 15% decrease for total prescriptions, a 9% decline in opioids in March, and a 26% decline in naloxone prescriptions in March, right at the center of the graph. So naloxone prescriptions declined significantly more than all prescriptions, and definitely a lot more than just opioids. So the decline definitely can't just be explained by the reduction in opioid prescriptions. Next slide, please. And we show that the number of individuals filling naloxone prescriptions has remained pretty low. There are some months where there's a little bit of an uptick, but it hasn't really recovered to its pre-pandemic level. And the weekly growth rate for prescriptions overall and opioids overall have also declined. Next slide, please. So we do break this out by payer. So this is primarily driven by Medicare and commercial insurance, who are the primary fillers of naloxone at retail pharmacies or mail order pharmacies. So the reduction from Medicare is 34%, and for commercial insurance is 31%, whereas individuals with Medicaid or cash payment, they didn't see a statistically significant decline during the pandemic, but they're not the primary fillers of naloxone at a pharmacy, so they would tend to get their naloxone from another source. Next slide, please. So some limitations of this study, first is that we're just focusing on prescription fills of naloxone. So we know take-home naloxone went down, but prescription fills we show also went down, but it is important to keep in mind this is a very particular sliver of naloxone access, and it doesn't measure take-home naloxone. And one thing to keep in mind also with the payer analysis is that we know many individuals lost their job during the pandemic. So if you were on employer insurance and you lost your commercial insurance, you may have switched to Medicaid if you qualified. So some of the loss in commercial insurance could be switching to Medicaid if we're just looking at trends overall. Next slide, please. So in conclusion, we show that naloxone prescriptions declined by 26% in March 2020, and it's driven by individuals on Medicare and commercial insurance, and it's significantly larger than the overall reduction in prescriptions or in the reduction in opioid prescriptions alone. Next slide, please. So one thing that we recommend is increasing funding for mail order and delivery of naloxone and other harm reduction supplies. This could help to decrease some of the fatal overdoses and just making sure that everyone who is using opioids, which is still going on during the pandemic, still has access to naloxone, which could save their life and at least get them to the emergency room to receive care. Yeah, thank you.
Thank you so much, Ashley. This is fascinating. And at this point, I want to pause. Please, you'll see on the Zoom to the audience, the Q&A button at the bottom of the Zoom screen. Please do use that. Please toss in any questions you have for Ashley or for our next presentation, and we'll hold questions until the end, but please do populate there, and we're going to try to get to as many as possible. Thank you again, Ashley. That was fascinating. Looking forward to the Q&A, digging a little deeper. And I'll pause here just so everyone sees Ashley's email and Twitter account. And next we have Thủy.
Great, thank you. Yes, so today I'm going to present a collaborative work with a really great team from different universities and institutions, including Indiana University, Johns Hopkins, Tulane University, and Rand. And in this study, we used retail pharmacy claims data from the COVID-19 database to examine the buprenorphine prescriptions for opioid use disorder during the early months of the pandemic. Next slide, please. So as Ashley and Clara already have discussed the motivation, why it is important to look into the intersection between two public health crises. So opioid epidemic is an ongoing public health crisis, and the pandemic imposed unique challenges to the healthcare system and to policymakers because of the substantial disruption in healthcare delivery during the pandemic, especially during the early months of the pandemic when policymakers didn't know what to do. And so that led to a significant increase in opioid overdose. And as you can see in the record number recently, next slide, please. So expanding buprenorphine treatment is a central policy to address opioid epidemic. And I will explain why it's important to expand buprenorphine, but like why this is a really like the major policy from the federal and local government. So as you can see in the picture here, buprenorphine is not only the FDA approved medication to treat opioid use disorder. There's other medication, including methadone and naloxone. Methadone and but they have a very different mechanism to work on our brain, and also the different treatment setting. So methadone and buprenorphine are opioids, while naloxone is a not opioid. It's an antagonist to block the effects of using opioids. So that is why naloxone is really harsh on patients. It's require detoxification and require close monitoring on patient. Methadone and buprenorphine are opioids, so it's bind to our opioid receptor and create some like effects in certain level. Methadone is a full opioid and buprenorphine is a partial opioid. So it's only bind to the opioid receptor like partially. So it creates some ceiling effects of using opioids. So it's like block the high feeling, but it's kind of like helpful to reduce cravings for opioids, and therefore it assists recovery. And then so this indicate that buprenorphine is a safe, effective medication to treat OUD. And also methadone, because methadone is a full opioid, so this is the only dispensed through the federal highly regulated methadone clinics, while buprenorphine is dispensed by qualified doctors and non-physician prescribers. So it's a very accessible even in rural areas or area with a lot of low-income patients, right? So that is why expanding buprenorphine is a key policy recently. However, it is before we conduct this study, it is unclear about buprenorphine use during the pandemic. And this study will address this literature gap and also like helpful for policymakers. Next slide, please. So in this study, we use retail pharmacy claims data to examine the secular trends of buprenorphine prescription for OUD before and after the relaxation of telemedicine use for buprenorphine prescribing in mid-March 2020. It also happened at the same time with the public health declaration for the emergency. And we also compare with any medication. And we also stratify national database by payer, including Medicaid, Medicare, commercial plans, and prescription paid in cash. This is the reason to look into the payer is important because like Medicaid is the major payer for treatment for OUD or buprenorphine. But a lot of prescription is paid in cash because of a lot of insurance rules and it's a lot of barriers. So that's why cash payer and Medicaid patients are really important in this situation. Next slide, please. So, so in this study, we used retail pharmacy claims from Symphony Health, thanks to the access to the COVID-19 research database. The database, as Ashley mentioned, is really rich. They cover over 90% of retail pharmacy claims. And we use very simple approach, but really powerful approach to answer the question. We counted the weekly number of individuals who filled prescription for buprenorphine between May 2019, the start date of the data available to researchers, until June 2020 is the time we stopped the analysis. During that time, we found is a million patients who fill buprenorphine prescription for OUD. And we also do the same thing with any medication for comparison. And we use interrupted time series analysis to compare two periods to examine whether there is any change in the level and growth rate in fill prescription between the two periods and compare with other medication for comparison. Next slide, please. So this figure showing the main results of our research letter. So as you can see here, the dark blue dots presents the counts of buprenorphine, like people who fill buprenorphine prescription per week. And the light blue dots present the number of individuals who fill any prescription in the same period. So the scales are different, but as you can see here, before and also the dashed line here represent the emergency declaration and also the midweek of March. So before the pandemic, we observed that buprenorphine prescription increased at a higher pace compared to any medications. So that is a good sign that we are in the right direction to address the epidemic. And then after seeing the pandemic, you can see there is a significant drop in any medication trends. Why we did not observe the significant drop in buprenorphine prescription. So and then the trends also become flat for both buprenorphine and any medication. So this is a interesting results. As you can see here, like immediately, since the pandemic, we see about 11% declines in all prescription. It's equivalent to 5 million patients that did not have access to their medication in general. So it's very interesting to see that. So next slide, please. And then we look into different payers for buprenorphine prescription. So the dark blue is Medicaid, light blue is the Medicare, commercial in orange one, and the gray is the cash. As you can see here, the prescription paid in cash declined significantly in both level and growth rate. There's no significant change were found in prescription paid by Medicaid. So it's a really interesting differences. And then for Medicare and private like insurance plans, they reflect or they follow the general trends of buprenorphine prescription. So there's a significant difference across payers for buprenorphine prescription. Next slide, please. So the first conclusion from our study is that the count of individuals who filled buprenorphine prescription flat or plateau, but did not decrease in early months of the pandemic. And then we compare with the abrupt declines in levels and growth rate for all medication. So this study provides some suggestive evidence that some of the early responses from the federal government to the pandemic, like relaxing telehealth use, work to reserve treatment access to patients with OUD. However, because the access to telehealth is not equal across patient, so there's a certain vulnerable population who could not have access to telehealth. So that is why we need to achieve equal benefits from this transition to telehealth. Next slide, please. So the second takeaway of our study is that we found that prescription paid in cash declined significantly compared to the greater stability in prescription paid in Medicaid or private insurance. So these results are likely related to the unprecedented job disruptions during the early months of the pandemic. And this is also consistent with the previous studies on the greater cost-related barriers among cash-only patients. In general, like cash payers can pay about $300 per month for buprenorphine treatment, while compared to Medicaid, it's really cheap for Medicaid patients. Therefore, it is we need further safety nets to alleviate income and insurance coverage losses. So this is the important lesson for future pandemic. And this also like the last takeaway from our research. Thank you very much. Next slide, please. And if you have any questions or comments, feel free to contact me. Thank you very much for the attention.
Thank you, Thria. This is fascinating. And please, everyone with questions, please feel free to drop them in the Q&A. And I can I'd like to kick off perhaps the conversation, the Q&A a little bit. So I saw that you both disaggregated by the type of payment for a prescription, but I'm interested, were there any other, maybe we can start with Ashley and then go to Thri, were there any other sort of stratification that you did with the population? I'm just thinking in terms of sex, in terms of there's interesting socioeconomic data, race data. I know we've wrestled with the missingness in race data, but interested if you saw anything within other stratifications or even stratifications within the different payment methods or within the different insurance. Yeah, Ashley, we'll start with you, and then Thri, I'd love to hear about your stratification as well.
Sure. So in our research letter that is published, we only stratified by pair, but in working with the data, we tried to stratify by race. There's about, I think, a 48 or 50% rate of missingness. So it's really interesting to look at. I think tough to get published in an academic journal. Similar with the income data, also really interesting to work with, but tough. And then we also, I think we have 2-digit zip codes. So we linked as many as we could to states that would link to one state. And we looked regionally at any differences. But you do end up losing a lot of observations. So with something like naloxone, where there's not a ton of pharmacy fills, it's a little difficult. But yeah.
And maybe if before we go to 3, just to double click on 2 things for the geographic stratification, because we saw in sort of the overdose deaths that there were some parts of the United States that were at 98% year over year versus 15% of the. Did you see? Did your analysis mirror, the access to naloxone mirror the increase in overdose deaths, or were there any major departures?
There were definitely differences by region. I know the problem is I've done this with so many different drugs at this point that it's hard to remember the ones that, since we haven't generally published those, it's hard to remember which is which, because I've also done it with Bup as well and a few other drugs. I think in most of the drugs that I've looked at, there's a lot of differences in the South. I can't say with 100% certainty that naloxone also followed that pattern, but generally that's what I've noticed with other drugs.
Got it. Thank you. And 3, maybe if you want to talk a little bit about other stratification, please feel free.
Yes, absolutely. So thanks to the richness of the Symphony Health database, so like researchers can look into the difference by gender, by age group. I think this is an interesting factor too. Also, yeah. So also the race. And so we have we drafting another paper that to look into the racial disparities in buprenorphine treatment. So the results are less striking compared to the results by payer. So that is why we have selected the results in this short research letter, but have a high impact to the community. And also another direction, as Ashley also mentioned, is looking into the regional variation in the treatment access or prescription. I think it's interesting, at least can do at the state level variation. As you can see here, for Medicaid, it's really helpful for patients to preserve the treatment access. And so I think it's interesting to look into the state already expanded their Medicaid expansion before the pandemic and see the difference. Of course, so the challenge to do some of the more serious causal analysis here is that the period of observation is quite short, only around 2 years. And within that time, with the pandemic, it affect everything, it affect everyone. So it's really hard to disentangle some of the policies. It's a really dynamic in policy perspective, but I think it's really fascinating. So in another project, we also interested in the costs associated with the prescription. That's also available in the data sets. Of course, it's a need cleaning, but we compare the cost to dispense prescription by Medicaid payer versus the prescription paid in cash, and it's a huge difference. So it's another direction of our team now.
Oh, that's fascinating. I'll be really eager to see the results from that. You touched on telemedicine and how that perhaps affected what we saw, and not quite the dip that we saw. Obviously, in naloxone, we saw this dramatic dip, and Bup, we didn't see the same in medically assisted treatment. So I'd love to go back to Ashley quickly. On the telemedicine front, was there anything that you saw or were interested in terms of how telemedicine did or could affect that dramatic drop in naloxone availability or in naloxone prescription?
I think naloxone is a little trickier in terms of if you'd be seeing a clinician for access to naloxone. I think usually you'd be getting take-home naloxone rather than a prescription. I think there could be some substitution there, but I think it's just generally a little bit of a different pathway. So I'm not sure about that. But I know in terms of bupe, something that was interesting, I think that I've looked at, and I imagine you definitely must be looking at too, is the differences in days supplied changing during the pandemic. And I think that's really something that's been really, really interesting that I think is across all drugs, but especially things like bupe, where it's really regulated how many days you can have at one time, letting people have longer prescriptions and things has been something that's also been particularly helpful, especially when you're using telehealth to see people.
Right. And did that change particularly during the pandemic? Was that one of the policies that changed at a certain date during the pandemic? And I'm interested, or in your work, Ashley, if you saw any changes, or are researching any changes. I'm actually not read up on whether that policy changed mid-pandemic or that was pre-pandemic change in regulation.
I think a lot of them were during the pandemic, so extending days supplied, and especially with bupe, the more regulated. But I'm sure you have a talk about bupe, so you can definitely take the floor on that.
Yeah, so there's a kind of like use for telehealth before the pandemic, but actually during the mid-March, then there's quite a lot of regulation to relax the telehealth use for buprenorphine prescribing. So I think it's like, as I mentioned in the presentation, is a SAMHSA rules relaxing telehealth use. And then also they allow like take home like medication with the patient, and also allow like increase days of supplies. So we also in the results that I did not present today in the increase in the duration of the medication. So we also see the increase in the prescription. For the Symphony Health data, if we look into the retail pharmacy claims, we could not distinguish between like the regular prescription or the prescription getting through the telehealth. So that is a kind of like some limitation. But yeah, I think it's a really interesting setting. Yeah, so I think this is the really big lesson for future pandemic.
And I'm interested to touch a little bit on what you were just talking about, Thuyen, from either of your perspectives. I assume, and the way of background, one of my first jobs in public health was working at a methadone clinic. So I've marinated in this, and I feel very strongly about medically assisted treatment and naloxone. But I think anecdotally, and I think we have seen the data that individuals who are their first prescription versus they've been on this for years, they know where their pharmacy is, they've been going to it, they have a relationship, like that longitudinal patient, they're very different. And I'm wondering if either of you have explored in your analyses these different types of prescriptions. Particularly, I'm very interested in those who received their first prescription during the pandemic, and whether those behaviors were distinct from these more longitudinal patients that had received prescriptions prior to the pandemic. Yeah, I was interested if you'd explored that at all. And maybe we can start with you and then go to Ashley.
Yeah, I agree. Buprenorphine initiation is a very interesting topic. And I feel it's an understudy currently. So that's why we working on like propose some study to distinguish like the different patient and clinician characteristics of like initial or new buprenorphine medications versus like continuous like buprenorphine user. So I think that's interesting. So I think one of the reasons why we lack of such like evidence is that like we see just recently buprenorphine expanding buprenorphine become a central policy. So a lot of new user of buprenorphine, but I think according to one of the recent work we found is about 9% of like buprenorphine user are the new user of buprenorphine. Does mean like before like like 6 months, they did not have a buprenorphine prescription, but then after that they have them. So yeah, so I think it's definitely interesting to look into the difference in characteristics associated with these user, and then we can target the underuse new user of buprenorphine, and then I think it's like the direction to kind of like continue address the opioid epidemic.
Absolutely. Ashley, I don't know if you have any other thoughts on these patient characteristics.
I would just echo everything that you said, definitely. In terms of naloxone, we haven't looked at new initiation of treatment, but we've been looking at that with several other drugs like bupe, also drugs for alcohol abuse, which has gone up quite a bit, alcohol use disorder during the pandemic. And I think the new initiation of treatment and the equity across that is something that's particularly interesting to me. And I think it's really important and something that obviously the pandemic has been terrible, but hopefully one of the things that we could get out of it is making these things more accessible and easier to initiate treatment for.
Mm-hmm. Yeah, I'm interested. Actually, one thing I would ask about naloxone in particular, because I know we've been indexing a little bit on medically assisted treatment as opposed to naloxone in the conversation. One thing I think that's come up a little bit in the discussion around the number of deaths that we saw last year is prescribing not only to someone directly who is receiving opioid prescriptions, as you talked about that, but also to family members, to community members. I'm interested in whether you were able to tease any of that out in the data. Are these opioid users, are these maybe peripheral? Are you able to get, and maybe what are the policies around expanding prescriptions, not just directly to someone who's receiving opioids or has a history of opioid use, but to the community of support around them, which is a little different than obviously the medically assisted treatment. Yeah, I want to pause there if there's any interesting data in that, or if we saw anything in the Symphony data in particular.
So that's definitely something we're working on now. So the great thing about the Symphony pharmacy data is you can link it to the outpatient data. And so I think that covers about 62% of outpatient visits. So while it's not perfect, you can get some indications of whether someone is having any kind of treatment for opioid use disorder. So it's not a perfect way to identify, but it is a decent proxy. And so looking at whether people are family members or people who use drugs, which is important because during the pandemic, a lot of people might not be seeing their family, so they may be reducing their fills because they're not using them or not seeing the family members that they would be filling them for. So definitely something we're actively working on.
Wonderful. And we have one final question. And again, to everyone in the audience, feel free to use the chat or Q&A to ask any final questions. One question I'd love to offer up was a little more general in nature. You belong to two of the most prolific groups and most advanced users in the database. We have a lot of very new users or people considering using the database and the resources in it, and particularly Symphony, obviously, because of its richness and breadth, is of great interest to many researchers. I'm interested just to talk a little bit about your process and what your teams did, and anything that research teams should know going into using the database generally, or Symphony in particular. Would love to just get a sense from all of you. Is there any sort of must-haves, must-dos, do-not-dos, anything that you think you wish you had known going into using the database initially? Maybe Ashley, I'll start with you this time, and we'll go to Thea.
Sure. I would say as an economist, I am a health economist, but claims data is tough. Like, it's hard to work with. And I think I definitely could have never done this without a team of, I have primary care physicians, inpatient physicians, everyone. They explain to me how they bill. I've also talked to pharmacists about the other side. And I think really getting familiar with the data is important. Sometimes you can pull something and think you have something, and then I would go, talk to a primary care physician who works in that area, and they're like, "Oh, maybe you're missing something. Like, go back and double check." And I think that's one thing, that just having a support system of people, or reaching out to people who have worked with the data in the past. You can always email me if you have questions. I'm always happy to help. But I think reaching out to your team, to Claire, sent a lot of emails to you guys asking for help, has been really, really helpful.
Great. And Thea, anything you want to add?
Yeah, so I agree with Ashley that it's important to have a collaborative and multidisciplinary group of researchers that you can learn a lot from each other. And some people can work directly with the data, and then someone verify that, and then someone have to interpret the results, something like that is really helpful. And so as you can see in these papers, like the approach is really simple, but the messages are powerful. So I think it's a really interesting kind of like territory for researchers. And for the using the data sets in COVID-19 database, I think it is really important to start with the like provided data dictionary. Important, and then try to reach out to the team to get like as much as data or information, additional information about like the settings of the data, like the sample, like the population, like the kind of like some. These are kind of limited documentation in the data sets, because as you can see, like they manage so many data sets in the database. So, and it's provided by like hundreds of providers. So it's really complicated to get everything. So, and the second, the third thing probably, because if you want to extract the data, you have to use SQL. And like I personally, I found it difficult at the beginning to kind of like learn SQL skills. So it's helpful that my team have a strong like data science students, that they helpful to kind of like teach you how to do that, and then you can do that yourself. And then I pull the data to extract them, and then use data. I'm CAPS data user, and then I use data for my follow-up like analysis. So I think that works fine. So it's a kind of like, but yeah, so like have a like some supports in terms of like coding, kind of really helpful for teams.
Yes, absolutely. And I want to emphasize a few things. First, the SQL piece, we know that is a tough part of the database, and we so appreciate is I mean, as part of my epidemiology program, they certainly didn't have a SQL course. Learned a lot of Stata, did not learn a lot of SQL. So we definitely appreciate that. And one thing to emphasize to those who are thinking about using the database or are new to the database, we've started a researcher forum, and there's a Symphony section of the forum where you can see all the questions that have been about the Symphony dataset in particular. There's also a lot of interesting conversations and questions about the SQL code, and there's actually some sample SQL code that people have written or shared, or our team has written, and we share it there. So really I want to emphasize the researcher forum. And if you have questions for these folks, I will say these two research groups are some of our experts in Symphony. They know more about the Symphony data than even we do at DataVent, even though we are technically supporting. So please do post questions there, and I can try to help to direct everyone. And yep, Alex just put in the chat, the website, the community website is right there. You have to be signed in to see all the questions. So if you don't see all the questions, just click login in the top right. But I think with that, I think we can close for today. I want to just thank our panelists so much. We've really tried to establish a little more of a community around the database as we have these growing numbers of publications coming out. We obviously will make the recording available to everyone who registered, including everyone who was here today with us. But a special thank you to our researchers for making time, to Ashley, to Thủy, thank you, and hoping to have you back for a reprise when you have your next papers out. Thank you again, and have a great day.
My pleasure.
Thank you so much.